Okay, good to go.
A very good morning to everyone. My name is Roshini and thank you for tuning in to our Facebook Live session. Our topic of discussion today will be on epigastric pain in children. And we have two speakers who will be presenting today. Our first speaker will be Dr. Sherina Shereen, our pediatrician gastroenterology, and she'll be covering on the causes of epigastric pain. And then our second speaker will be Dr. Syariz, our pediatric surgeon, and he'll be covering on the endoscopic side of it. So both of them will be discussing on epigastric pain in children. Now, I'm sure this must be a familiar topic to most parents. As many parents know, children and stomach ache seem to go hand in hand, right? Commonly known as abdominal pain, it can be caused by a variety of reasons, and one of the reasons could be epigastric. It can be difficult to know the best ways to help your child and when you should seek medical treatment. Hence, we have both our specialists here today to explain to us what we should know and what we should do when a child has epigastric pain. Now, if you have any question pertaining to today's topic, please drop your questions at the comment box, and our speakers will be happy to answer them during our Q&A session. All right, so without any further ado, please welcome our first speaker, Dr. Sherina, to our virtual webinar. Hi, Dr. Sherina. Hi, Doctor.
Hi, Roshi. Hello.
Hi, Doctor. How are you this morning?
Good. Thank you. How are you?
I'm good too, Doctor. Thank you so much for allocating your time today. And it's a pleasure to have you join us for our talk. So without wasting any time, you may begin your presentation on epigastric pain.
Okay. Good morning, everybody. My name is Dr. Sherina, pediatrician at Avisena. I have a special interest in pediatric gastroenterology, and I've been asked to talk about specifically epigastric pain in children. Okay, so when we talk about epigastric pain, we need to know where the epigastrium is to know where the location of the pain. So as you can see on this slide, the epigastric region is the area above the child's umbilicus, below the chest. Okay. Now, there are many causes of epigastric pain. I've divided them here into organic causes and functional causes. So organic causes are as listed here. And normally when we investigate these types of causes of epigastric pain, you would be able to see changes, for example, on the endoscopy. However, with the functional side of things, children present similarly with similar symptoms, but endoscopy and other investigations are completely normal. So as mentioned before, epigastric pain is pain in your upper abdomen. The pain may be acute, it may be persistent, it can be chronic or recurrent. Especially when it's recurrent and chronic, it is a frustrating concern to the child, parents, and sometimes to the doctor as well. A differential diagnosis of abdominal pain in children is very wide. It varies with age, gender, genetic predisposition, nutritional exposure, and many other environmental factors. So we have to bear all of that in mind. So the way I work through this is the diagnosis of epigastric pain in children. I've divided into 5 main components. And this includes, the most important, I feel, is the history. Because more than 2/3 of the time, the differential diagnosis that I come up with is solely based on the history. So a good history is paramount. So once I have my suspicion of what the cause of the epigastric pain is, I do a complete physical examination in order that I can be more assured of the diagnosis that we are potentially getting. Investigations, including lab testing or imaging studies, tend to be about, confer about 5 to 10% of the picture in order to get the diagnosis, okay? Once we have a full rounded history, physical examination, investigation findings, then with slightly firmer diagnosis in mind, I start on empiric therapy even before the upper GI endoscopy is done. You can see that although endoscopy can be necessary, it is way down on my list of things because in children, it's not as straightforward as in adults. Endoscopies are done under general anesthetic, so it's an invasive procedure with other risk factors, including anesthesia. So epigastric pain, where the child may indicate the location of the pain by pointing with one finger or the whole hand to the epigastrium. So the epigastrium here is, this is where roughly where the umbilicus is. So the epigastrium, if you look at the diagram here, it's where the stomach is mainly located. So behind the stomach is your pancreas. You might have a little bit of the left lobe of the liver within the epigastric area as well. Now, John Apley is a pediatrician based in Bristol many years ago, who made a very clever observation that the further away the child points from the umbilicus, the more likely that the cause of the pain is genuine and of organic disease, as opposed to it being a functional pain. And children may rate the intensity of the pain from a scale of 1 to 10, as you can see from this cartoon, or if younger children who are unable to appreciate the number scale can point to a series of graded faces from a smile at no pain to frown and tears at the worst pain with a score of 10. Now, night pain or pain on awakening or usually early morning suggests a peptic origin. So peptic origin is concerning acid or inflammation within the stomach area. While pain, for example, pain that occurs in the evening or during dinner is the feature of constipation, which is not where the epigastrium is. So children often deny heartburn, but I feel because they don't know how to describe the pain and they don't understand what a heartburn is. But you may look for other features of peptic disease, including early satiety. So this is feeling full, even when you've only eaten a little bit, bloatedness, etc., nausea, and the complications of acid reflux, for example. So you can delve into a little bit about history of possible respiratory complications of reflux, including chronic cough, reactive airway disease, persistent huskiness of the voice with persistent laryngitis, which may be more prominent than chest pains or vomiting itself. In severe acid reflux disease, children's teeth can also show signs of acid erosion. A diary that lists diet, symptoms, associated features of about a week, for example, can be invaluable since it will indicate the potential causes of the child's symptoms. A careful review of recent medications is also important. We live in an era where there are many viruses going around at the moment. Young children have episodes after episodes of febrile illnesses necessitating the intake of fever medicine like ibuprofen, which may predispose the patient to gastritis. And in the adolescent, for instance, acne medication may cause esophagitis, which is inflammation of the esophagus or our food pipe. Family history of peptic disease, irritable or inflammatory bowel disease, pancreatitis, liver disease is also important to know because the risk of our young patients having similar problems is higher compared to those without a family history. Severity and influence of pain on the child's daily activity is also very telling. So school attendances usually takes a hit. Now, this may not necessarily be a child with organic disease. So those who are affected by functional abdominal pain tend not to go to school either. So you'd want to delve a little bit into the history of whether, you know, is the peak of the pain, the epigastric pain, is it first thing in the morning when the child is getting ready for school, and when the child skips school, does he or she remain fairly well at home, for example? Is there a variation between days over the weekend, so school off days as opposed to school week? Has she or he stopped doing the things that they like most, for example, sports or going out with friends? So these are very telling to say that, okay, this may not be functional, this may be genuinely an organic cause to the abdominal pain. Whenever possible, a few minutes should be taken alone, especially with our young adults or adolescents, to address concerns in the absence of parents in the room in order to get honest answers about possibly personal issues or psychological fears and stresses that's exacerbating their symptoms. So next is physical examination. So you can see here in this cartoon that the abdomen is divided into 9 squares. And where the epigastric area is, I can get the mouse working, there we are. So it shows in the epigastric area, mainly you would expect symptoms of indigestion or heartburn. Stomach ulcers occur in this region as well. Inflammation of the pancreas, pancreatitis, and just slightly lower to that, sometimes stresses and anxiety can cause similar symptoms. Now, because of the important interaction between abdominal pain and nutrition in young children, growth parameters are essential. So we always check weight, height, and plot them on the children's growth chart in order to see what their growth velocity is. Examination of the pain should be performed gently at first, and deep pressure gradually can be undertaken in areas where you suspect that the child might be complaining of pain in order to elicit signs and symptoms of enlarged organ, etc., etc. Investigations is next. So I do simple investigations first because common things are common. A full blood count tells quite a lot. It's a simple test, a cheap test that you can see the total cell, white cell count that tells you whether there is inflammation, because white cells fight infection or inflammation. You can evaluate for anemia because hemoglobin would be low in cases, for example, of chronic gastritis or ulceration of the stomach because you have ongoing blood loss, although microscopic. ESR or erythrocyte sedimentation rate would tell you whether there is chronic inflammation accounting for the symptoms. Platelet counts are frequently elevated as well in inflammatory diseases, and that can be seen in the full blood count. In young children, we automatically check urinalysis because urinary tract infection is so common and can present in a similar way. Biochemistry profile to evaluate your liver enzymes, and amylase, which is an enzyme that the pancreas excrete, is also important because pancreatitis present with epigastric pain. Now, Helicobacter pylori is known is a bacteria, naughty bacteria that causes gastritis, that causes ulceration in the stomach and duodenum in children. The gold standard is to do an endoscopy and biopsy, but then, as I mentioned earlier, in young children, this is not always possible. So we prefer a non-invasive alternative. And here in Avisena, we do a urea breath test. A stool antigen can also be sent, but I'm not aware that this can be done in Malaysia, at least. Occasionally, we need more in the way of imaging, and normally ultrasound scan seems adequate, but very occasionally we do need a more detailed scan with contrast, either abdominal CT or MRI. Once we've done all of those, the first step in empiric treatment is to educate the child and parents about the differential diagnosis that you're suspecting and offering them options for appropriate intervention. For example, a prospective symptom diary should be used, easily done, to document the frequency of pain, related events, response to intervention that parents may have taken. The child's response to empiric treatment is part of the diagnostic evaluation itself. For example, improvements on acid suppression medication would support the diagnosis of peptic disease, for example, gastroesophageal reflux disease. Upper GI endoscopy, or OGDS, in children is rarely indicated as a first-line investigation. However, this is sometimes still necessary for us to come to a diagnosis. Biopsies will be taken from various places, even if the endoscopy itself does not show any inflammation within the naked eye, because microscopic changes might still be present to help us diagnose these peptic conditions. The endoscopy is generally indicated in the context of active, persistent, recurrent bleed, or children who comes in with significant morbidity, for example, weight loss, anorexia, severe chest pains. Children with suspected uncomplicated peptic disease are usually treated first with medication, for example, Nexium or Losec, which is a meprazole, a type of proton pump inhibitor, or PPI. Most of the time, endoscopy is deferred for those who still present with pain 4 to 6 weeks after treatment, or those with recurrent disease or suspected Helicobacter pylori. I'm just going to go through here about specific disease states that can cause epigastric pain. We've mentioned Helicobacter pylori. So Helicobacter has been known since the 1980s as a gram-negative aerophilic bacterium that causes chronic gastritis and peptic ulcer disease in adults. Soon after that discovery, Drum and his colleagues confirmed the similar role of Helicobacter in chronic antral gastritis in children. As you can see from the picture here, it has a lot of tentacles, and that is one of the reasons why it's very difficult to eradicate Helicobacter, because it can swarm into the layers of mucosa of the stomach. The bacterium produces cytotoxin in the form of urease, mucinase, superoxide dismutase, which then act together to produce gastric and or duodenal injury. The major risk factor for peptic ulcer disease in childhood is a genetic predisposition. We see that 50% of children roughly with duodenal ulcer have a first-degree relative with peptic ulcer disease. Helicobacter is the commonest cause of stomach and duodenal ulcers in children, and the prevalence of duodenal ulcer is 2 to 3 times higher in boys compared to girls, and it's equal for gastric ulcer. Here you can see a superficial but fairly large ulcer in the duodenum there, and this is signified by the pale area here, and quite a hyperemic or quite red area around it. So this is the ulceration of the duodenum. Antral gastritis is one of the other common presentations that we see in children who have infection with Helicobacter. So the antrum is the lower part of the stomach here. And antral gastritis is a common peptic presentation in children, and they usually tend to present with chronic epigastric pain. So this is epigastric pain that has lasted for longer than 2 weeks in an episode. They also feel full easily with episodes of nausea. Some may have lost a little bit of weight. Gastric emptying, so the emptying of food from inside the stomach into the small intestine can also be impaired. So this then would distend the stomach further and cause backflow of food particles and acid up into the food pipe or the esophagus causing reflux symptoms. Normally, results of stool tests for blood or radiographic studies are usually normal, and the acute gastritis can follow on from an acute illness from a viral origin. The other peptic disease that is quite common is GERD, or gastroesophageal reflux disease. In normal circumstances, we all have a little sphincter called LOS here at the base of the esophagus or food pipe before it enters into the stomach. So LOS is short for lower esophageal sphincter. And the idea and the role of LOS here is to keep the acid content, the stomach content down in the stomach and not let it go back up. But for whatever reason, for example, in hiatus hernia, which is a condition that one might have been born with or develop as a result of obesity, the effectiveness of the lower esophageal sphincter can be defective, so it becomes loose. And hence, when the stomach churns, acid content along with partially digested food can go up the lower third of the esophagus, causing spasm and pain, and also in a chronic condition, it can cause inflammatory changes, chronic inflammatory changes. On the left here is a normal, what normal lower third of the esophagus should look like. So it's pale pink, yeah, no bleeding and no ulceration. On the right, or in the middle photo here, this is reflux esophagitis, where acid that's gone up backwards to the lower third of the food pipe or esophagus has caused a lot of ulceration and inflammation, and possibly stricture, so narrowing as the healing ulcers heal and causing problems. And in the far right is an example of what teeth acid erosion looks like. So I would have hoped that my fellow pediatric dentists would refer me children whom they have seen a lot of severe acid erosion in the children's teeth, so that we can actually investigate things further. Eosinophilic esophagitis is a condition where you get inflammation. It's a chronic inflammation of the stomach. It can be eosinophilic gastritis as well, and also the esophagus, caused by a combination of an allergic and immune response to a particular allergen. So here you can see the white patches, which is classical of eosinophilic esophagitis. And you can also appreciate that there is triangulation here. And when it is supposed to look circular and nice, but due to chronic inflammation from this condition, you get triangulation, what we call trachealization of the esophagus. And sometimes you can get paper mache ulceration as well, because it is so friable from the chronic inflammation. Now, having discussed a little bit about possible organic causes of epigastric pain in children, we have to mention the non-organic side of things. Now, functional dyspepsia is a group of condition where children present similarly, like they would have had GERD or tummy ulcers or Helicobacter pylori infections. But in fact, when they're investigated, both in the blood tests or ultrasound or even endoscopy, investigations have all yielded normal results. But unfortunately, children still present with these conditions. So they have upper abdominal bloating, they can have heartburn, they can have nausea, and sometimes severe belching. This is based on the Rome 4 criteria of functional abdominal complaints in children. So this is the latest knowledge that we have on functional diseases of the abdomen. And two syndromes, and in particular EPS or epigastric pain syndrome seems to be very predominant in the functional dyspepsia family. So the criteria for this is that one would have to have at least 3 episodes of epigastric pain or heartburn a week, and also that there is no organic pathology that could explain the symptoms, and the symptoms is great enough to have an impact on the life, normal daily living and activities of the child. Symptoms must have been present for over 6 months, and the criteria is fulfilled for over 3 months. The cause of functional dyspepsia are multifactorial. So you can see that there's lifestyle factors, specific food factors. So fatty foods, acidic food, stress, anxiety, or being overweight are all not in the best interest of the child. The same group of disorders tend to have visceral hypersensitivity. So any gastric distension can yield an over-the-top response. So gastric dysmotility, so emptying of the stomach might be delayed and therefore causing more distension and the feeling of a tummy upset, even though there is no physical abnormalities that we could see on endoscopy. Final comments. So once the etiology or the cause of the epigastric pain has been established, now begins the process of patient and family education. So treatment will depend on the cause of the epigastric pain. Careful follow-up is absolutely necessary in order to monitor compliance to treatment and restoration of normal activities and appropriate family interventions. Going back to school, I always say going back to school is most important. Because the longer you stay off school, the harder it is to return. And this is especially true when your child has epigastric pain from a functional point of view. Growth parameters must be followed carefully. Support groups can be helpful for family and children. But I feel most importantly, the child must feel that the doctor believes and understands that the pain is real and that he or she is not making this up. And the child's input is as valuable as the parents, and that information shared in confidence will be kept confidential if at all possible. I think that's the end of my talk, and I pass the camera back to Roshini.
Yes, thank you so much, Dr. Sherina. That was indeed really an informative session. You've covered quite a lot, you know. Yes, so we do have a few questions here from the audience. So I'm going to begin with it. So, Doctor, as you mentioned, you said that epigastric is actually where the middle upper abdomen is, right, just below the rib cage, isn't it? So what are like the severe complications if epigastric is not treated?
So epigastric is just a term that we use to describe the area. So it's not a disease, it's not an entity. So epigastric pain is pain that arises from pathology of whatever organ that is found in the epigastric area. So the most common problems or organ that is problematic there would be the lower third of your esophagus. So that's our food pipe that can be inflamed if there is acid reflux. The stomach that can be inflamed from gastritis, for example, from Helicobacter, as I said, or inflammation of the pancreas, for example, from whatever cause can cause problems and symptoms. So like any other illnesses, if the symptom is not treated appropriately, so for example, if you've got chronic gastritis from Helicobacter pylori in children, so the chronic inflammation can predispose the child to having ulceration of the stomach or the duodenum. And this has an impact in later life as well, because we know that adults with untreated, poorly treated chronic gastritis from Helicobacter has an increased risk of gastric cancer or mild lymphoma within the stomach. So it is something, if it's there, it's causing symptoms, and you see ulceration or inflammation on the endoscopy, it needs to be treated.
Yeah. All right. Thanks, doctor. Another question here from a parent. Is there any pain relief or what can we do to calm my child before bringing them to meet the doctor? Is there like a care home thing?
Because we're talking about epigastric pain now, we're not just talking about any other pain. So I'm just going to focus my answer to epigastric pain. So when we get epigastric pain, it is so if it's an organic cause, we think, so it is acid related and infection related a lot of the time. So if the child wakes up early hours of the morning, for example, 2 or 3 o'clock in the morning, crying in pain, pointing to the upper abdomen where the epigastrium is, and we're concerned that this could be what we call gastric. A lot of our population, our community calls it gastric, doctor. Yeah. Yes, it's just gastric, doctor. So when that happens, you can calm the child down, giving him or her a glass of milk, for instance. So so the alkalinity of the milk will help neutralize the acid, hopefully, in order that the child may then go back to bed, and then you can then come and see the doctor in a non-urgent manner.
Okay. All right. And then another question here about food. So once epigastric has been diagnosed, what sort of food should a child stay away from?
Yeah, so I think generally speaking, when you have inflammation of your stomach, you want to have boring, bland food, which I don't think any child is keen on. So I normally would say no spicy food, no greasy food, no food that is very high in carbohydrates, because the digestion of carbohydrates then produces wind, and that can cause distension, which can then precipitate epigastric pain. Also, things that have a cocoa base or Milo, chocolates, and all of that, that causes delayed motility as well. So the tummy is already upset. It's not functioning and digesting very well. It's taking longer time to expel food boluses into the small intestine. So when we take a lot of cocoa-based food or drinks, that makes it even worse.
Yes,
so,
aggravate it even more.
So, and then I would strongly suggest that they don't drink anything caffeinated or gassy drinks.
I guess water would be the best options.
That is the problem, isn't it? That not a lot of children would
want
drink water in the quantity that they need to. But we as parents, we have to do what's necessary.
Correct. Yeah, we'll do what we can from our end as well.
The other thing as well, acidic things. So if the tummy is empty, so don't eat fruits that are acidic, lemon and orange.
Oh, fruits as well,
So acidic stuff.
Correct. All right, that's very well, Dr. Sherina. Thank you so much. So that's the questions that all we have from the audience. Thank you for answering those questions as well on epigastric pain in children and which parents can actually also relate to. So thank you very much, Dr. Sherina, for your session. Yes, it was really nice to have you on board with us today. Thank you so much.
Thank you.
Okay. All right. So everyone, that was Dr. Sherina Shereen, our pediatrician gastroenterology from Avisena Women and Children Specialist Hospital. All right, so let's now move on to our second speaker for the day, which is Dr. Syariz, our pediatrician surgeon, who's also practicing in Avisena Women's and Children Specialist Hospital. And he'll be basically covering on the endoscopic side of it. All right, so let's welcome Dr. Syariz to our virtual webinar. Hi, Dr. Syariz. Can you hear me? Hi.
Hello. Hi.
Wow, doctor, you look all ready and steady for the...
Yeah, I'm just finished operating next door.
Oh, okay.
Yeah.
Doctor, thank you so much for your time, and it's a pleasure to have you join us today on our topic on epigastric pain in children. So earlier, just a moment ago, we had Dr. Sherina presenting about like the common causes of epigastric pain, the region, in our abdominals and all that. So, and what parents should really know about epigastric pain. So doctor, could you please elaborate on where do you actually come in, your role, and also about endoscopy?
First of all, I must say thanks to Sherina because she has covered the topic quite extensively.
Yeah.
making my session much easier because everything was well explained earlier.
Yes.
All right. Now, here in Avisena, we work hand in hand between myself. Dr. Sherina is a pediatric gastroenterologist.
Yeah.
I'm a pediatric surgeon. So sometimes or commonly, when a child presents with any abdominal pain or epigastric pain, they can either go to me or to her. No issues, all right, because we work hand in hand. Now, back to your questions. When should a child go to a pediatric surgeon? Okay.
Yeah. Yeah.
These, if you're talking in an acute situation, all right, as mentioned by Sherina earlier, the presentation of epigastric pain can be very acute or chronic. Okay, chronic means it has been going on for quite some time.
Yeah.
In a non-emergency setting, then you can always come at any time or any convenient time which is convenient to you.
Yeah.
But if the cause is something like a pancreatitis, which can cause a very acute and severe pain, then you have to come into the emergency straight away.
Okay.
Usually, yes, that's when the pediatric surgeon comes in.
Mm-hmm.
Or if you have any acute severe epigastric pain because of there is a perforation of the gut, or if there's a duodenal ulceration which needs an urgent endoscopy, so usually that's where I come in. All right, but if I'm not around, Dr. Sherina is around, so she will see the patient first. So it doesn't really matter if either you come to see me or you come to see Sherina first. Doesn't really matter.
Okay. All right. So, doctor, I realized that you've got a machine next to you that you would like to show our audience.
It's half of a machine, okay?
Half of a machine,
All right. I will
Yeah.
show you. Of course, my topic, or mainly I will tell you what endoscopy is all about.
Okay.
All right.
Yeah.
Endoscopy is a small procedure where we visualize the entire gastrointestinal tract. Okay. From the mouth, it goes into the esophagus. All right. Then it goes into the stomach, and we can visualize until the first or second part of the duodenum. All right. In children's, most of the pathology happens around the stomach, some in the duodenum. That's the common places if there's any causes of the epigastric pain. If you, as you can see in the pictures
diagram,
there,
Yeah.
so that's where we can visualize the esophagus, the stomach, and the duodenum. All right, I'm going to show you the machine now.
Yes, please do.
All right. This is an expensive machine. All right, now this is what we call an endoscope.
Endoscopy.
We can focus this to this, all right? Okay, this is just part of it, all right? The tip of it, all right? These are fiber optics around the tube. At the tip of it, there is a camera which will show whenever we put the endoscope in, can show through a camera or a TV. That will be my guide, all right? So as you go in, all right, there is some lumen inside here, which allows some pumping of gas to opens up the way the esophagus as I push the scope in,
Okay.
all right?
Okay.
So this is roughly, as you can see, all right, it's difficult to visualize by giving numbers, but if you can see, this is my little pinky here, all right? It's slightly smaller than the endoscope, all right? So that is the size of the tube that will go in through the gastrointestinal tract during the procedure, okay? Now, this procedure is actually, is a very, very short procedure, probably less than 10 minutes. Your child will be sedated,
yeah,
throughout the procedure, and they
Okay.
will wake up usually probably around 10, 15 minutes after that.
Oh, okay.
All right?
Yeah, yeah.
Now, any questions at the moment?
No, actually, I was going to ask you about the sedation, but you've just answered.
Oh, is it? All right, all right.
Yeah.
A sedation will be
Yeah.
given first before we
Yeah.
start the procedure, okay?
Yeah.
Your child will be, I usually will scope on child when they are on their side,
Yes.
all right? Left side down.
Correct.
So, and the monitor will be right in front of me. I didn't bring the towel for the monitor, but this is connected to the camera and the TV monitor. And during the procedure, what we do is usually we will take a few biopsies in any of the areas which are quite suspicious for us, all right? The suspicious means I will see some redness, some erythema around the area in the stomach. I might see some erosions. I might see some ulcerations. I might see some white plaques and so on.
Okay.
All right?
Yeah.
Now, can I put this thing down?
Oh, yeah, you
Sure.
can.
All right. This is expensive. All right. I don't want to
Yeah.
break it.
Sure. Thanks, doctor. So usually, like, as you mentioned, those are the usual findings that you will find when you're doing an endoscopic in children, right? So.
Okay. Now, where shall we continue?
So like you mentioned before, that was the usual findings that you usually would find when you go into the patient's abdominal area. Is it like the ulcers, like you said, the pellets, is it?
Plaques, yeah, some white plaques. Like I think Sherina showed the pictures of the eosinophilic esophagitis, the white plaques around that area. You might see some of that.
Yeah. So those are the usual findings that you usually would get from the endoscopy.
Yeah, those suspicious areas is where we will take a few biopsies. If I forgot to mention, biopsies involve putting in a wire through the endoscope, all right?
Okay.
Through the endoscope, then it will come out. We will visualize through the TV. It's a small pipe of all the tissues there, all right? These tissues are then taken out and sent to the lab to be read by the histopathologist.
Okay. All right. And also, Dr. Syariz, I think this is a very common question. What should a parent prepare before the procedure begins on their child? Is there any preparation, mind preparation or something for the parent? Yeah.
Well, it will be quite surprised if you're not worried about it. I'll be surprised if any parents will not be worried about it. But I must say that the procedure is a very, very short procedure. All right, it's quite a safe procedure. Okay. Now, in terms of the preparations, in any case, when we want to give a child some sedation or an anesthesia, the stomach needs to be empty. Okay. So means that involves that the child will need to be fasting for 6 hours or 4 hours or even 2 hours. All right, depends on what they consume. Okay, this is important because, for example, if they're not fasting, they're eating something. When I put my scope in, I probably will see a Maggi inside there or even a bread inside there. That will obscure my view. All right, so it's important that 4 hours or 6 hours is followed so that all the food are digested within. So that the stomach and the visualization will be clear.
Will be clear for you. Okay. Good. And is there any side effects when you do the child face when you do an endoscopy? Is there uncomfortableness?
Sure. Now we will divide it in two things. All right. For any cases, if there are any side effects or you would say complications from the procedure, surgery-wise, all right. During the procedure, I mentioned earlier that we will have to insufflate some gas. Okay, into the tummy to open up the way so that we can visualize. Okay. So sometimes, although during the procedure or at the end of the procedure, we will suck all the air out, some of the air will still travels more distally into the small intestine. So they might feel a bit bloated sometimes. Okay. Now, if you can also imagine when we put the tube in, the tube will curve quite steeply from the pharynx, from the mouth, into the esophagus. So sometimes they might complain of sore throat.
Sore throat,
after the procedure. But usually the anesthetist will give some sort of local anesthetic spray in that area. That will help. Okay? Those are the two common ones. All right. You might see some little bleed around the mouth area sometimes. Okay? So the common ones. You're talking about a bigger or more disastrous complications, which rarely happens. You might have some perforation. Okay, I haven't seen one. I haven't done one. Thank God.
Thank God. Fingers crossed. Yes.
Yes, we have to inform the patient or the parents of the possible complications. All right, that is from the surgical side. Now, other complications or side effects related to the anesthesia. Okay, like any other anesthetic drug, they might have some drowsiness. They might have some. They can feel a bit nauseous post-procedure, but most of the medications given are short-acting. So usually if they have a side effects, it will not last that long.
Okay. All right. All right. And also, doctor, what is the recovery period once epigastric is diagnosed? Usually, how long does a child take to recover?
Depending on the cause, right? Depending on the cause. If it is a straightforward enteral gastritis, organic, once you start all the acid suppression drugs, they will recover quite quickly, all right? On the other hand, you're talking about, say, for example, the H.PYLORI. The treatment alone consists of giving 2 antibiotics with an acid suppression drug or proton pump inhibitor. Well, the regime is at least 7 days. So you will see the improvement gradually in that case.
Yeah, yeah, that's good, because Dr. Sherina also mentioned that it's very important for the child to go back to school as well. If they miss out on school, you know, so like, it's good to know that the recovery period is also quick, so that the child could recover and get back to their daily activities as well. Yeah, yeah. So doctor, is there any like final comments you would like to share with our audience on endoscopy?
Well, do not be afraid.
Yes.
Your child has to go through the endoscopy procedure.
Yeah.
All right. It is only about 10 minutes.
Yeah.
All right. Or less.
Yes.
But usually 10 minutes is pretty adequate. Yeah. Usually the child will tolerate the procedure very, very well. Okay.
Yeah.
And rest assured they are in safe hands.
Yes, yes, I think that's very important as well. All right, thank you so much, Dr. Syariz, and thank you for showing us the equipment, because I think parents who are viewing, our audience who are viewing this our current live talk would be probably at ease to see like how the endoscopy actually looks like, and the way that it enters into the child and all that. So thank you so much, doctor, for sharing, and also for your time. So that was really an insightful session from yourself and also from Dr. Sherina. So we have reached the end of our session. I would like to extend our sincere thanks to our speaker, Dr. Syariz and Dr. Sherina, for giving us their time to do this health talk for us. So you have definitely provided key information on our topic today, which is epigastric pain in children. So remember, parents, if your child is experiencing serious abdominal pain, please make sure you consult a doctor right away. So if you're looking to seek medical advice from our pediatrician, you may reach out by calling us at 03-5515-1888. So that's all from me. Thank you for your participation and taking the time to join our live session. Goodbye, everyone. Stay safe and take care.
Bye.